Hi, thanks for having me here, and thanks for sticking around till the end of the day. I'm sure you guys have heard lots of talk on pain management. Hopefully, what I try to do with my lectures, especially for docs in practice, is a bunch of take-home points. So hopefully we'll do that. There's a lot changing in pain management today, a lot more expectations on us, especially in terms of opioid use. My training, again, I did internal medicine, then a geriatric fellowship, but I'm certified in hospice and palliative medicine as well, and I kind of practice in all of those. So I do some nursing home work, I do hospital, I do home care. So I get what it's like to deal with the opioid prescribing in all the settings and how difficult it's become. So we can talk about that. Dr. Munson heard me give a similar talk at the ACOI portion of the OMED, and she thought this might be some good take-home stuff. So hopefully it is, but I'll be able to answer some questions. So I never usually talk about something without defining it. And when I looked up pain, and even in the Random House Dictionary, it's interesting that it mentions bodily, mental, or emotional suffering due to injury or illness. Now, I did not receive any training in terms of emotional suffering when we talked about pain management. Most of us learned pain management from the surgeons at the bedside, where they used Demerol when it was IV and Vicodin for oral. We all remember the days when we had those triplicate scripts here in Michigan, and so in order to prescribe something stronger than Vicodin, the docs would say, "Oh no, I don't have that special prescription pad, so I can't give you anything stronger." And then there was a big push nationally that we're not doing a good enough job here in Michigan. We got rid of the triplicate scripts, and now there's a big push that maybe there's a problem with opioid prescribing. But an important part to understand is it's not just physical pain, which is what opioids treat, right? So there's mental or emotional suffering. If our patients look this up, they're going to expect that we're going to mention or treat mental or emotional suffering as well. So you have to look at the whole picture. An example of a patient, I do a lot of hospice work as well, and I went to see a young guy who had end-stage AIDS, who's living in his sister's basement. And they said, "Dr. Carron, you got to go see him. His pain's 10 out of 10. And he was on about 400 of MS-Contin, a long-acting morphine, 3 times a day, which is a pretty good dose. So I went to see him, and he said his pain was in his legs, and he was having trouble walking. Well, that's what the nurses told me. So when I went to go see him, he says, "Oh, Dr. Carron, can I get you some coffee?" He runs up the stairs, gets me something to drink, runs back down, and I was like, okay, so if it's leg pain and it's debilitating, it's obviously not physical. There's something else going on. So we just had to have a long talk and really had to get him treated for depression, for emotional suffering, and we were able to eventually reduce some of his opioid use. So you gotta look at the whole picture when you're looking at pain. And Margot McCaffrey is a nurse leader in pain, and really we need to practice where we believe whatever the patient says. And that it's still a problem in healthcare today where patients get labeled drug seeking, or they're faking it, they just want the drugs, they don't have real pain. We can't treat patients like that. We have to walk in and believe them and kind of figure out the whole picture. So why are we talking about this? If I asked you, everybody here, who thinks we should do a better job with pain control, I'm sure you'd all say yes, right? So why don't we do a better job? And if this is an example of the incidence of pain as to data that we're not doing a good job. And I use some data here on cancer patients, because imagine if we're doing this poorly with cancer patients where we know they should have pain or we believe they have pain. Imagine how we're doing with osteoarthritis that's disabling, or fibromyalgia, where it's not so clear that they have terribly disabling pain. So almost half of all cancer patients have pain, and nearly 75% with advanced cancer have pain. 40 to 50% have moderate to severe pain, and 50 to 80% do not obtain adequate pain relief. So that's a sad state of affairs, and this is still current. And why wouldn't we do a better job? Again, we'd all say, well, I treat pain, or I believe we should do a better job with pain. Certainly our patients should think we would do a better job with pain, but there's misunderstandings regarding addiction, psychological dependence. A lot of times they hear, well, they could get addicted, and we hear that from families too, but a lot of doctors believe too, I don't want to make them addicted, or uncontrollable side effects. Well, she's 80, she can't have morphine. Not true. It's just a matter about dosing. And we don't believe the patient. We don't have to go through everything our patient's going through in order to believe them. And then not empathizing enough with the suffering patient. So we have to have empathy for the patient and really understand that this pain is disabling, even if we think that maybe they're just not tough enough and they should be toughing it out. Failure to keep up with scientific advances. There's no way as a primary care doc you can keep up on all the new antihypertensives, all the new insulins and diabetes treatment, and all the new pain medication. So you don't have to. Know when to refer is what I always say, or pick a few meds that you're comfortable with, and then know when to refer when you're outside your comfort zone. And I think the biggest problem is not relating pain to function. It's hard as a doc, and I'll tell the nurses, I'll go around in the hospital and the nurses will say, oh, Dr. Carron, their pain's terrible. They're asking for pain medicine all the time. And I'll go see the patient. I'm like, well, how's your pain? It's fine. I'm fine. You know, they don't want to complain to the doctor. So it's really hard to increase pain medicine. I believe the nurse, but it's hard to increase pain medicine when the patient says everything's fine. But what can you do? Get the patient up out of bed and walk them. If they're in so much, then you see, wow, they can't even walk. They're in so much pain. Maybe just laying there, they're not in pain. But relate pain to function, okay? And then federal and state legislation, sometimes, you know, we're worried about what the DEA is going to say. I think that's not even really a problem if you're appropriately prescribing. And then patients create barriers too, why we're not doing a better job. They believe pain is an inevitable consequence of cancer. You know, I have cancer, I should have pain, so I don't want anything for it. They don't want to be a problem patient, so they don't want to complain. They don't want to, they're worried about reporting pain because it might be worse disease. And sometimes with cancer it might be, but their neighbor may have had some hip pain, went to the hospital and never came home. So they may be afraid to tell their kids, oh man, my hip's really hurting. So they don't tell us when it's really hurting. And then patient and families worried about addiction. I still have hospice family probably once a week tell me they don't want morphine for their family member because they're going to get addicted, even in the throes of the last days of life. So that's a real problem. So I'll talk a little bit about how to manage pain, but that's the big way to look at pain in two big areas is the first is nociceptive, okay? And so there's, it's somatic or visceral, so bony, muscle, or visceral. You know, we've all had the bad flu where that's some of the worst pain you can have is visceral. So think of pain in two ways in terms of nociceptive or neuropathic. Neuropathic involves nerve pain. It's the sheets even hurt when they're, or burning or stinging, more common at night. I just got a call from a colleague in West Virginia who has a young person, unfortunately, but really end-stage disease, having myoclonic jerking from increasing dilaudid doses. Well, we kind of talked through the case, and there's probably a huge neuropathic component to the pain, which opioid does not treat. Opioids do not treat. So you really have to differentiate if it's nociceptive or neuropathic and think about your treatment from there. But that's just a really broad way to break down pain. And then caused by direct disease damage. Now, there's things that we do to patients that hurt, and we have to consider this. If we're going to do surgery and they're on chronic opioids, we have to be prepared to give them what they get baseline plus more. Right? I see a lot of times an older woman comes in with a hip fracture, and maybe she's on chronic fentanyl for chronic back pain. But she's confused, right? Old ladies with hip fractures get delirium. They get confused. So she comes in the hospital. What does the emergency department do, or the house staff? Take off her fentanyl patch because she's confused, right? They think it's from the narcotics. And then we do surgery on her, and we give her less pain, and then we prescribe post-operative pain management, and it's less medicine than she was even getting chronically. So we undertreat patients. So we have to know when we're doing something that's going to hurt, schedule something for pain management. So we cause direct disease damage. And then 25% of pain is caused by treatment, radiation, chemotherapy, medications, physical therapy, and occupational therapy. Especially for older adults that are confused, schedule something for pain before you get them up or get them to therapy. An older adult who's confused can't use PRN medication. A lot of times for older adult hip fractures, I might schedule even Tylenol a couple times a day, and then use PRN opioids for pain control. So anticipate pain and know that sometimes what we do causes pain. Now, psychosocial influences is something we haven't had a lot of training on, and we have to think of it. A good example, my dad had a compression fracture of his back, and he was, 80, he was still working, totally independent, and couldn't get out of bed, it hurt so bad. And he was overwhelmed by the fear of death, that he was dying from this. And it was so interesting to me because he was so independent, but it was because he'd never really not been able to completely do everything for himself. So he needed adjuvant treatment for his fears to get the pain under control. His pain was never going to be under control because his anxiety was so high about what the fear meant. So imagine somebody with cancer that has pain, that anxiety, that fear, that loss of work. You have to ask your patients who's paying the bills. And help them deal with that, refer them to social work, refer them to, I saw a patient yesterday at the hospital who was a dentist, and I think maybe because he was a professional, he had cancer for a long time, I finally was asking him about does he have a trust, does he have, how is his wife doing with caregiving, driving him to appointments, and his wife broke down, he broke down. I mean, she's overwhelmed with driving him. They were totally, and they'd never been referred to even our cancer center that has a huge amount of resources for them. The American Cancer Society, they never got a referral. I think we tend to assume patients that are stoic or especially well educated or have to seem a good support system, that we don't ask about those other things. And you know, he's in the hospital for uncontrolled abdominal pain. So we were treating his pain, but all of these other things were not being assisted and were making his pain worse. His fear of being a burden on his wife was a long thing that we talked about. It hadn't come out before. So we have to ask about all of those things in terms when you see somebody with chronic pain. So general principles of pain management. We were all taught, at least I was taught, if a patient comes in, for example, abdominal pain, you can't give them anything until the surgeons see them and until we have a diagnosis, right? Because you might mask the pain. You don't know how severe it is. Well, we don't do that anymore. Don't delay treatment while assessment is underway. And I see that a lot of times, you know, the nurses will call me, the patient fell, they have some hip pain, can I get an x-ray? Yes. Well, in the meantime, you got to ask if they have something for pain in the meantime. So don't wait for treatment to, for your workup before you treat. Then the general principles of pain management as well. Do a complete assessment. We were all trained well in, for example, chest pain. What makes it better? What makes it worse? Does it radiate? Have you had it before? What associated symptoms do you have? Do that with every pain and document it in your records. When you hear about docs who get in trouble for prescribing opioids, it's because they're not documenting that maybe the non-opioids that they tried didn't work. So document the associated symptoms, document that what you tried worked, and that you assess it the same way every time. You know, use a pain scale, 0 to 10 being the most common, you know, 0 being no pain, 10 being the worst pain you ever had, but use some sort of scale. So you have a consistent assessment, and use one that your staff can do in your office, and then it's repeatable and shows that the pain isn't being controlled. So how do we manage pain? So there's pharmacologic and non-pharmacologic. Don't ever forget about the non-pharmacologic, and we'll talk about that. So education, patient, family, all caregivers. I have a rule that in my practice, I do not start morphine specifically, but usually, I can't say every single time, but certainly every single time with morphine, but most opioids, I call the family. And certainly if the patient can make their own decisions, I ask the patient for permission, but and again, I do a lot of hospice. I don't just automatically start morphine. I make sure the family knows. But a lot of family members, especially for older adults, might not want their family member to even get, you know, Vicodin, which now is Norco, which is, you know, hydrocodone, because they're worried about confusion. And if the family member walks in and they're confused and they find out they got a new medicine that's an opioid, they're going to be angry. And then you kind of lose trust, then the patient's suffering. So educate the patient and family and all the caregivers about your plan. And they might be a little bit confused at the beginning. They might be a little bit sleepy, but it should get better with time. So so the education piece to do better pain management will help avoid those families refusing for the patient to get the medication in the future. And then ongoing assessment of outcomes, regularly review your plan of care. Whenever I see a patient that I'm managing pain, I write, you know, their pain now is this, they're functionally able to do this now when they couldn't before, and they're tolerating without adverse side effects. That's what I document on almost every patient I see, even in rounds in the hospital every day, because then I'm checking for adverse side effects. And then if I have to give more or change to a stronger opioid, I can feel comfortable that I'm doing the documentation required to move them along. And then interdisciplinary care, again, you might need a social worker, you might need a chaplain. You certainly will need therapy. You might need, like, therapy can do a lot of TENS units, a lot of topical treatment, stretching, a lot of the non-pharmacologic interventions, and then consultative expertise. Find a doc in your area that does interventional pain management or has a pain clinic that has all of these things there, or the integrative medicine, or a lot of things that Dr. Munson was just talking about. But I get that a lot of times pain clinics are tough to work with as a primary care doc. You might send them and then they fire them because the patient didn't exactly follow their contract or they don't take their insurance. So I empathize with primary care docs where the patients come back to you saying, they're not going to prescribe my Norco anymore. What do I do? So, but you have to try to work with your consultant and find one that will talk to you before they fire the patient. So again, what is the for workup? What is the cause of the symptoms? Do a reasonable workup and check for non-physical causes. So we've talked quite a bit about that. Use an appropriate scale. So pain in the elderly. From the HCPR guidelines, they're at risk for undertreatment of pain due to inappropriate beliefs about their tolerance of pain medication. Don't use the term, they're 80 years old, they can't have this. Don't use age or ageism as simply a reason not to use something. Do you have to keep in your head that they're 80 before you prescribe? Absolutely. The mantra of geriatric medicine is start low and go slow. So you start at a very low dose and increase it very slowly. And an example for me, it might be Neurontin. That's my drug of choice for neuropathic pain. If you look up the starting dose, it's 300 milligrams 3 times a day. I start my patients at 100 milligrams at bedtime. Now, I can't give you the science behind that. It's just my clinical experience because I've toppled a lot of older adults into delirium, even with Neurontin, and I have much more incidence of it with Lyrica. But I do 100 at bedtime for a couple nights, then 100 twice a day for a couple nights, then 100 3 times a day, if I'm treating neuropathic pain. And that's kind of my practice. Then I let them stay on it for a while to see if it's going to help. But my intent is that I'm not going to get a ton of pain relief with 100 milligrams. I mean, the total maximum daily dose is 3,600 milligrams. So I'm not thinking I'm going to get a lot of pain relief, but I'm going to avoid side effects. So that's just one example of, think of your age of your patient and think of their comorbidities, but don't use it as a reason not to treat them. And then cognitive impairment. Again, I cannot stress that enough. If they cannot ask for PRN medication, don't use PRN medication, or leave it, but write PRN restlessness, PRN yelling, PRN moaning, or educate your staff, especially if you do nursing home care. This is huge. The care plan should absolutely list what behaviors they're treating for PRN, wincing, moaning, whatever if they can't express a scale, using a FACES scale or some sort of for cognitive impaired patients, scales that you can use. There's many of them out there. But do frequent pain assessment to see if they're working. A lot of times my older adults in a nursing home, the nurses will call me for something for sleep or something for agitation. And because the nursing home regulations are so strict on any psychotropic medication, a lot of times I'll just schedule some Tylenol, like 500 at bedtime, 500 twice a day. And just start there. Maybe it's pain that's coming out as yelling that they can't really express. So cognitive impairment, use it as a tool, but recognize it. And again, my best example is the hip fracture patient. Imagine a patient, if you have them on PRN medication, check and see if they got any. And you imagine a patient with a fracture, no pain medicine for 24 hours. It's pretty unbelievable that it's understandable that they would be confused and agitated. Sure, the pain medication can cause delirium, but so can the pain. Okay. I put this in here because it's in any guidelines, anything that you read about pain management. We shouldn't be using placebos. I think we use it much less. When I was a fellow at the nursing home, a lady all she could say, very few words, but she would walk up to the nurse's station and say, pain, pain, pain. And the nurses would go and get a Tic Tac and give it to her. Now, she took it and walked away and stopped saying pain, pain, pain. So could you argue that it worked? But it's horribly indignant. It's not appropriate to use placebos at all in pain management. And I know when I was a resident, I don't know if you guys did it, but occasionally we'd worry about that patient that was drug seeking, and they'd be screaming in pain and say, I need Dilaudid, and we'd push normal saline. just to see if they got relief. Can't do that. Now you guys are all looking at me like I got two heads. None of you guys ever did that. Well, we did it. So signs and symptoms of pain. So these are some examples of pain verbally. Of course, if the patient states they have pain, they moan, they cry. Nonverbal signs, loss of function, eating, sleeping poorly, agitation, change in sleep, loss of interest in activities, facial grimacing. The AMDA clinical practice guidelines for nursing home care, if you do nursing home care, is a great tool for pain management in the nursing home and the cognitively impaired. So this here is still today the standard of care in pain management, the World Health Organization 3-step ladder. I think this is probably going to go away soon. A lot of experts in the field are looking at changing this, and mostly changing it to get rid of the middle step. But if you follow this step ladder, you can be comfortable, again, eventually prescribing opioids. So you start with step 1, right? Mild, don't forget the non-opioids. Now, if they come in with 10 out of 10 abdominal pain and they have a ruptured bowel, you're not going to give them Tylenol. So take this with a grain of salt. But if they have whether it's musculoskeletal pain or abdominal pain or headaches or whatever pain it is, start with acetaminophen, start with non-steroidals, but again, you have to be very careful with non-steroidals in the elderly, and use adjuvants. Adjuvants there mean things for sleep, things for bowels, things for neuropathic pain. So things that go along with pain management to help optimize the regimen. The antidepressants, those are what adjuvants mean. Then if those fail, in an example again, I might schedule 500 milligrams of acetaminophen 3 times a day scheduled, with 1 every 4 hours as needed, or 1 every 6 hours as needed for breakthrough. So that's what a scheduled with something around the clock, even for non-opioids, is the standard of care in pain management for chronic pain. Mostly what I'm talking about here is chronic pain, not acute hospitalized pain. So moderate, and then if they fail that, you can go to moderate opioids. And the same thing, scheduled with something for breakthrough. And then if they fail those, you can comfortably go to for severe pain, go to the pure opioids. So we'll talk a little bit more about these. So acetaminophen, it's a great drug. It comes in liquid. You can use suppository if patients are having trouble swallowing, and certainly they have all different formulations of it. The standard is changing now, where you really don't want to exceed more than 3 grams a day in the elderly of acetaminophen. For most of my career, it's been 4 grams a day, but in the older adults today, it's really try to stick to under 3 grams. Do I occasionally go over 3 grams? Yes. Do I ever go over 4 grams? No. Our life, and I don't know if you guys feel this way, but my life's been much easier since they made the hydrocodone 325 tablets, which is now Norco. They don't actually even make Vicodin anymore, for those of you that may not know, because that was a combination of hydrocodone with 500 milligrams of acetaminophen, and they couldn't, you could only take 8 tablets in a day. And that was 4 grams. Older adults now with 3 grams, they could only take 6. Now with the 325 compound, they can go 8 or 12 a day, depending on the patient. But But I never write an order. That you will not find one of my patients that has any orders altogether that they can exceed the maximum amount of acetaminophen I want them to get in a day. And this is a take-home point for you guys. I want to give an example. I don't know how many of you guys ever prescribed Vicodin ES. Right? We all did it at one point or another. Thankfully, that's off the market. That was hydrocodone with 750 milligrams of acetaminophen. Right? So they could not even take 1 every 4 hours without exceeding 4 grams. And I had so many patients come to me in the nursing home with an order for 1 to 2 Q4 PRN. My husband had hernia surgery, and that was what the surgeon wrote for him. 1 to 2, Vicodin ES, 1 to 2 every 4 hours as needed for pain. Now, he wanted 2 before we left the recovery room, right? So I said, oh no, you're not sending me home with only 3 more tablets to give him in the next 24 hours without exceeding his maximum dose. And I said, if he could legally take 2 every 4 hours, based on what the physician wrote, and I bet you he would have, and many people would have, and he could have. You can go into hepatic failure with too much acetaminophen in a day. So that was, to me, that was overt malpractice. And I said to the nurse, this is malpractice, because he could, if I wasn't here to tell him not to, he would take 2 every 4 hours of this medication. And the nurse said, well, somebody's asked the surgeon about that before, and he said, well, he should only take 1 at a time, probably, and he'll probably sleep through the night and not need 1 at night, so he'll use 5, right? Even if that's true, that's not what he wrote. So if you're going to write a script where you're going to exceed the daily amount of acetaminophen, or you're going to have you need to document if you give Norco to your patient or something with acetaminophen in it, that they don't take over-the-counter acetaminophen, but put in there no more than this many tablets in 24 hours. If your script allows too many, past 4 grams, or for older adults past 3 grams, just put right at the bottom of the script, do not exceed this many tablets in 24 hours, and you're set. And you don't have to change your practices at all. And I used a ton of Darvocet too, right? They had 650 milligrams of acetaminophen. So this is really, this acetaminophen compound, again, with the Norco now, the hydrocodone acetaminophen 325, is life-changing for us in terms of that. But I have lots of nursing home patients, or not my patients, but I see lots of nursing home patients where there's an order for acetaminophen 650 milligrams every 6 hours, PRN, and then there's an order for hydrocodone acetaminophen, PRN as well. So if they took all, if a nurse didn't add that, then you're counting on your nurses to add up the acetaminophen in both tablets in a 24-hour period. For sure, your nursing home patients, you should be writing do not exceed more than 4 grams in a day, or more than 3 grams in a day, because then you're kind of covered legally, but you're expecting the nurse to add them up. Now, a lot of hospitals have safeguards in place from their pharmacy that the machine almost adds up for you. So the hospitals, you're a little bit more protected, but be careful because of the hepatotoxicity. But use it. I don't want you to be afraid of the drug. It's a great drug. Just know how you're prescribing it. The biggest mistakes I see docs make is you just don't understand the compound of the drug and really what's in it and how often your patients are using it. So non-steroidals, great for pain, but in older adults, really just time limited. There is no indication for non-steroidals on a scheduled basis in an older adult. And I know I have a lot of patients coming to me recently on Mobec at the nursing home. It's still a non-steroidal. It can cause anorexia. It can cause renal impairment. It can cause GI bleeding. We need to use something else to control their pain than non-steroidals for older adults. If I use it, I might write 400 milligrams of ibuprofen 3 times a day for 48 hours, really just to get them over the bridge of an acute inflammatory process. I personally do not use long-term NSAIDs, even some of the more safer ones. It doesn't mean you can't, but your down row better be keeping a close eye on their blood pressure, close eye on their renal function, close eye on their appetite and their weight, especially in the nursing home. So what I use a lot, even in non-hospice patients, is prednisone for an acute inflammatory process, an acute ankle sprain, 10 milligrams of prednisone daily for 5 days. It can make them feel better. It can still treat their inflammatory pain. It's a great adjuvant to pain management when there's bony pain or inflammatory process. Especially in end-of-life care, I use a whole ton of steroids. Oh, I just talked about my next slide for you. But so the benefits of it, right? It can make you feel better. So it improves mood, it improves pain, it improves appetite. So it's a really good drug, but you cannot use steroids long-term in non-terminal patients. Okay. You guys all know that because of side effects. But in my terminal patients, I go to dexamethasone sub-Q in the home, and we can do it so when they stop swallowing. So it's a really good drugs that I think are underutilized, especially at the end of life. So step 2, once they fail your non-opioid, use weak opioids. Hydrocodone, I've talked quite a bit about. Codeine you can use, but it has a much higher risk of delirium in the elderly and a much higher risk of constipation. I don't use it a whole lot. It doesn't mean you can't, but it's probably better to work towards hydrocodone. And then here's the list of strong opioids. Probably morphine is the most common. It's the most common. I like to use it because it comes in every route available. It's long-acting, it's short-acting, it's a pill, it's a liquid, it's injectable. So I should be able to treat any patient with one drug. A big mistake I see a lot, and I will tell you at my own hospital, our standing orders for post hip and knee replacements or hip fractures is, morphine PRN IV, Norco PRN IV, and Tramadol PRN. Not IV Norco, I misspoke, but PRN Norco, PRN Tramadol. Right, 3 different opioids. So essentially you're saying to the nurse, here nurse, you decide how bad the patient's pain is, you decide which drug to give them, and then the nurse might figure it out. Oh, they really, when their pain is this, they need morphine. When their pain is this, they need that. But then what happens 12 hours later? A new nurse comes on, right? So then she might try a Tramadol, and then if that doesn't work, a couple hours later, give them a Norco, a couple hours later, give them the morphine. You're markedly increasing your risk of delirium and really not adding a lot of extra pain relief, because opioids work on mu receptors. So all of these opioids compete for the mu receptors. So they don't often add much more pain relief, but can add more metabolites. So that's why I like morphine. But the stigma with it is really a barrier. A lot of times families won't let you give it. So then I use Dilaudid, or which is hydromorphone. I do use some OxyContin, but because I do, or oxycodone, it only comes oral. So that's kind of hard to use in hospitalized patients, and it's hard to convert. Fentanyl is a great drug, but there's not really an oral short-acting. You may have heard of Actique. It's the fentanyl lollipop. I don't use it because it's so expensive. It's hard in the home. There's risk of abuse because it really is a lollipop. Most insurances don't cover it. So when you use a fentanyl patch, you have to use a different opioid for breakthrough, which is okay. But again, you're creating that increased risk of side effects. But the one thing I can, I'm sure it's coming up here, but so know your pharmacology too. Another big mistake I see, especially in the hospital, is morphine 2 milligrams IV every 4 hours as needed. Well, if you understand when the patients reach their half-life here, orally they reach it at about an hour is when they reach their maximum effect. IV, they reach their maximum effect about 6 minutes. So if they go 4 hours, they're going about at least 3 hours with no pain medicine whatsoever. So then what happens at 2 hours and 3 hours when they're asking for more and more, they get labeled drug seeking. So if you're using IV medicine, it really needs to be prescribed probably every hour as needed, or at least every 2 hours as needed. If you're doing every 4 hours and they're on nothing else, you're underdosing your patients, and you're potentially creating pseudo-addictive behavior where they're acting like they're addicted, but it's more because we're undertreating the pain. So understand how long your pain pills work. These short-acting, immediate-release preparations should be dosed every 4 hours. As needed, or you could schedule them, but it's 4 hours. If you schedule something every 4 hours, it means they got to wake up at night. If they're needing something every 4 hours around the clock, then you want to use a long-acting preparation. So adjust the dose. You can adjust the dose daily because they're going to reach their maximum effect within a day. If the pain's mild to moderate, increase it by 25 to 50%. If it's uncontrolled, increase by 50 to 100%. And you can adjust more quickly for severe uncontrolled pain. So what I mentioned, I talk about this because we're talking about how fast we're getting pain under control. With these immediate release, you can titrate them pretty quickly. But again, so you start with a PRN dose of, or these immediate release, add up what they're using in a day, and then start long-acting. So if you used short-acting morphine and they were using 5 milligrams 6 times a day, and their pain was controlled, you could switch them to, that's 30 milligrams, 15 milligrams of long-acting morphine every 12 hours. And then they get something continuous around-the-clock pain control and use the PRN for breakthrough. That's really the standard of pain control. So the extended release preparations, again, improve compliance because it's only maybe a 12-hour pill or at the most an 8-hour pill. You can't crush or chew these. That's really important to know. If you have a patient with a feeding tube, there is a long-acting morphine called, Cadian is the trade name. It's a capsule. You can open it up and put it on applesauce or something soft and put it through a tube, or for patients that are having trouble swallowing, it stays extended release even if you open up the capsule. But any of these tablets, if you crush them, they become immediate release. And that some of you that may have heard of the Oxy abuse or the OxyContin abuse, it was, I think it was a 160 milligram tablet. the kids were crushing it, and it became immediate release and taking 160 milligrams of short-acting oxycodone and dying from it. So that's why they took that off the market. But so you have to be careful with these long-acting medications. Adjust the dose every 2 to 4 days once steady state is achieved. And I don't know if you guys had a chance to walk around the booths in there, but there's, I should have brought the book down with me, but there's a booth from a state of Michigan about opioid use. And our maps where you can register as a doc and find out what opioids your patients have been using. It's free. You can look it up in a minute and find out where they've been getting drugs, who's been prescribing them, and it's a really great service. So you should pick that up. But they also have information on the REMS, long-acting opioid regulation from the FDA. Have most of you heard of that? The AOA has a grant where, but it doesn't matter where you get it from. They have information on how to attend this program. I actually am one of the speakers on it. There's a 2-hour or 3-hour program, and REMS are resource education and mitigation strategies. Some of you may be familiar with it for an example like Accutane, where if you want to prescribe Accutane, you have to fill out this long piece of paper and send it in. That's a mitigation strategy to help us appropriate prescribe. Because of the recent abuse of long-acting opioids, the FDA has put out a recommendation that physicians attend this training, this 2 or 3 hour session on long-acting opioids in order to prescribe long-acting opioids. It's still a recommendation, but all the experts who put together the presentation think it's probably going to be mandated. So if you have an opportunity to attend it, either at a conference or they could do it at MOA here next year if they want to. The AOA has a grant to give these lectures, so but you can find out where they're giving them, and he has information on that, and then you just attend the course, and then you would have met the requirements to prescribe long-acting opioids. The reason I bring it up here is they talk a whole bunch about not crushing the medications and appropriately using them. So that's something you guys want to look for. So I kind of talked a lot about morphine already. There's no maximum dose. The dose is the best dose is best pain treatment with the fewest side effects. And don't be afraid of it. Really, don't be afraid of it. But just learn how to use it. So oxycodone, the biggest time I use it is when families or patients say, I know morphine. That's when I go to oxycodone. Or a drug that I use a whole bunch is Percocet, which is oxycodone with acetaminophen, and it's got 325 milligrams of acetaminophen. And it's cheap. It's pennies a pill. So most insurances will cover it. So but it is oxycodone, so it's the same class as morphine, but it's only short acting. So but I use a lot of Percocet in patients. So, but if there is a long acting OxyContin, great drug, works just like morphine, where it's long-acting and you use something short-acting for breakthrough. It's just expensive and not as covered by a lot of insurances. You know, we don't need one more pre-authorization to fill out, right? So, and Dilaudid, again, great drug. I use it in the hospital a lot. I use it in a lot of my home patients, but the most of the time that I use it is when I want to limit the amount of fluid I'm giving a patient, where I need a lot of opioids, and it's much more concentrated than morphine. The biggest problem with Dilaudid is it doesn't come long-acting, and it only comes in a short-acting pill. So if you use it in the hospital and get good pain control, what do you send them home on? You cannot do good pain management chronically with a pill every 2 to 4 hours. Because if they sleep 5 hours, they wake up with no pain medicine in their system, and they're in a pain crisis. So that's why I don't like Dilaudid, because it's really hard to manage pain outpatient. The other thing is, I think most docs, most nurses don't understand how potent it is. And I can give you an example. You know, I will write for 5 milligrams of morphine IV on a patient every 2 hours PRN. Well, the nurse will come and say, you know, she's such a tiny lady. Are you sure you want to give her that much? And I'll say, oh, well, no, why don't you give her a milligram of Dilaudid, right? Which, if you know the equal analgesic dosing, 5 milligrams of morphine is equal to 1 milligram of Dilaudid. But even my residents, so I make a joke about it, but it's a true story. Now I educate that nurse right there and said, how come you're comfortable giving a milligram of Dilaudid and not 5 of morphine? But my bigger concern are my residents, because they will regularly right, for 2 milligrams of Dilaudid on almost any patient without even thinking. Well, and how many times have they ever written 10 milligrams of morphine IV? Probably never. So the biggest problem with Dilaudid is docs don't understand its potency. And then more concerning than in the hospital even is then when you transition them home, if you got them on IV Dilaudid in the hospital and then on day of discharge you put right for Norco, the patient's gonna be back in the ER with uncontrolled pain. So I don't mean to scare you, or I don't mean to sound like demeaning, but just know your drugs and use your equal analgesic tables. There's an app for your phone that you can get to look up how to convert medications to orals when you're ready to take them home, and get them on something oral before they go home. Really, if they're in the hospital, get them on something oral before they go home so you know their pain's gonna be controlled. And fentanyl, again, a great choice, but if it's peeling or if it's a patient who's sweating a lot, it can have some problems. If it's peeling or not sticking, it's not being absorbed. If they're sweating, it can accelerate the absorption, especially if they have fevers. So you want to be aware of that. In cachectic patients, which a lot of our older adults are, it's a lot of times not absorbed well. You really need some fat on you to absorb it. In children, it's approved in children, but it says right in there they have to be over 120 pounds. So I've asked the reps, what about an older adult who's 100 pounds? Well, it's fine for them. So the science says it's okay, but just be careful in your cachectic patients. And just know that it takes 24 hours to even start working. Again, I see a lot of docs, patients in the hospital on IV Dilaudid, they put a fentanyl patch on them and send them home. It's not gonna work for 24 hours. So if you're using fentanyl, know that it takes a while to start working. Know that you really only can titrate it every 3 days. It is not for acute pain, it's more for chronic pain. Again, a great drug, especially in the nursing home, it significantly reduces nursing times. They put on a patch every 3 days versus even a 12-hour pill. But just understand its use. We don't use it a lot in hospice because it's cost, mostly. Demerol, we shouldn't be using at all. I think soon I can take this out of my lecture completely. It's off most hospital formularies for pain control. If it's on the formulary at all, it's more for NLB or maybe endoscopy. But I'm sure you guys too. We use Demerol and Vistarol on everybody when I was a resident, on everybody. So we don't use it anymore. Methadone, I mentioned here, this could be a 2-hour lecture in and of itself, how to use methadone. I just mention it here because you may come across patients that were on it and that are on it. It's not just used anymore for heroin withdrawal. It's a great pain medication. It treats somatic pain and it treats neuropathic pain. You can use it short-acting and long-acting. It does come IV, but really hard to use IV, really risky to use IV, and it's used a lot orally. I use it a whole bunch, but you have to be really careful prescribing it because the half-life is so long. Now, what I put every 7 days titration here because that's kind of how I practice because I'm very cautious, but depending on what you read, it might be 5 days you could titrate it. But if you're gonna start it, I maybe start 2.5 twice a day or 5 twice a day and then watch them for a week. You still have to use some other opioid for breakthrough pain, but it's a good drug to use. And if you see your patients on it, don't be afraid of it. Just ask them what they're using it for, who's prescribing it for them. And then if you're going to use it, really read a lot. Most of the time, if I'm converting from one drug to another, I have to look up how to dose it because it's really, really strict conversions and things. But it's a great drug to be using, especially in end-of-life care. Tramadol, I think, has kind of become the drug of replacing the Darvocet we used to use. A lot of now since hydrocodone has become a C2, a class 2 drug since last October, I think this has become the drug that has replaced even Vicodin, because we can at least call it in. We can't, hydrocodone now you can't call in for your regular patients. In my hospice patients, I can only get an emergent supply if I call it in. So Tramadol, I think, has taken its place, which is, it's kind of sad to me because it has a high risk of delirium, and it is an opioid, and I don't think we take it seriously enough. And I've precipitated so many deliriums. When I was a fellow, it was a new drug and we tried it, that I didn't use it for a long time. I'm using it more now, and you can get some good pain relief. but just start really slow. A lot of times I start 25 milligrams twice a day. It comes in a 50 milligram tablet, split it in half, and then titrate from there. But you can start 50 maybe twice a day to start, and then go from there. But don't, if you don't do 50 to 100 milligrams every 4 hours, it's too much in the older adults. So it's an okay drug to use, but be careful using it. And make sure it has a lot of drug interactions, especially with some of the other psychotropics. So understand its use. So we talked about this already. Pain meds for chronic pain, use something around the clock with something for breakthrough, and try to limit your number of opioids. How do you dose? Breakthrough dosing, use immediate release, and it's 5 to 15% of your 24-hour dose. So if you have a patient on MS content or long-acting morphine, 15 milligrams twice a day, that's 30 milligrams. So your breakthrough dose would be, I kind of just use in my head, 10%. Would be 3 milligrams, or if I use a liquid morphine, I might do 5 just because it's easier for patients to dose. But about 10% of their totally daily dose is what you use PRN for breakthrough pain. And your goal for pain management is never 0. The goal is optimal function. And you have to explain that to your patients. I'm not going to make your pain go away completely. I'm going to make it tolerable so you can function. And I try to practice where they use maybe no more than 2 to 4 breakthrough doses in a day. If they're using them more often than that, then I need to increase my long-acting. So know towards the end of life if they're making less urine, they have renal failure or any hepatic failure, decrease your dose. Just a take-home point here too, in patients with renal failure, renal insufficiency, morphine is really not the drug of choice. Fentanyl is the drug of choice, like dialysis patients, things like that, because it's there's less toxic metabolites. But even Dilaudid or Norco or hydromorphone would be a better choice than morphine in renal failure patients. So alternate routes of administration. This is just to let you know, if you have patients that you're sending home on hospice, we can do almost many routes at home. Subcutaneous infusion, transmucosal, there's a lot of compounds that we do topically. So know that all these routes exist, and if your families want to take the patients home, try to support it. We can manage most things at home. And in terms of the swings in plasma concentration with short-acting meds, just prepare the family that initially they might be a little bit sleepy, but it should wear off over time. And certainly if the most common side effects are sedation, itching, confusion. This is with the pure opioids. After a few days, they should get tolerant to it. So it should get better. If it doesn't, then you change to a different opioid. The one symptom that they don't get tolerant to is constipation. Every patient that you write for opioids, you should write for something for bowels. This is, we already talked a little bit about equal analgesic tables. There's so many out there. They all have limitations, but just use something. When you're converting from one drug to another, reduce the dose by 25 or 50% because you don't know exactly how the patient's going to tolerate it. Don't forget about non-pharmacologic pain management, neurostimulation, TENS units, acupuncture, guided imagery. I recommend all of these. I tell the patients there's not some science behind it that I can tell you the percentage of patients that improved from it, but I can tell you there's chronic pain is a complex syndrome and you need other treatments besides just medicine. But whatever it is, and if patients come to me and say, do you mind if I do this? I say, no, but just let me know so that if you're taking something herbal, I can check and make sure it's not interfering with your medication. But all of these things can have help because the pain, again, is not just physical. Dr. Munson did a great job talking about all of these just before me. So don't be afraid to use high doses of opioids. Myoclonus, if they're getting jerking, it's probably too high a dose or because they're not clearing it as well as they're dying. Allodynia or hyperalgesia can also, where everything hurts and you're giving them more medication and it hurts worse. That's hyperalgesia. You got to reduce the dose or move to a different opioid. So I talked about this a little bit. These are some common side effects. Usually the mantra of geriatrics is you don't treat a side effect of one drug with another drug. you stop that drug. But in the end of life, we might treat pruritus with an antihistamine. We might use Ritalin to counteract the sedating effect of opioids. This is more end-of-life care, but I just introduce it to you out there as knowing that there's some things we can do. And if you have a hospice that you're working with or even palliative care, call them and say, is there something else you can do for this patient? So opioids and respiratory depression, again, we all learned COPD patients, you can't give them opioids. Now it's part of the treatment for heart failure and COPD, right? So respiratory depression sometimes is your intent with morphine, to make them breathe a little easier. Your intent is never stop breathing, but just prepare the family that that's your intent. Especially at the end of life, we use opioids for dyspnea. But to actually cause profound respiratory depression, it's usually going to be a patient who's not been on opioids before and too big a dose. So if you start low, know your patient, titrate slowly. This is not a big problem. So I kind of talked about constipation already. If the hand that writes for the opioid should write for the motility and not just a stool softener. Don't use Colace, just Colace. Use a motility drug like Senna. I start with 2 Senna twice a day a lot of times. I'd rather make them a little loose, or 1 Senna twice a day and increase it quickly. A lot of times I use Senna S, which has Docusate, which is Colace with it. That's a great drug. But if you're going to use bulk forming agents like Miralax, just remember the recommendations are to take it with 8 ounces of water. Most older adults won't sit and drink a glass of 8 ounces of water in one setting. So if you're going to prescribe it, make sure they're drinking. They're good drugs, but make sure they're drinking. I kind of already talked about these. I just mentioned here opioids and tolerance. Tolerance means the need to increase the dose over time. It does not mean they're addicted. If a patient's been on opioids for 2 weeks, they might need a higher dose just to maintain the same pain relief because their body gets used to it. That's tolerance. That's not addiction. Physical dependence is similar to tolerance. Again, if they're on it for 2 weeks, they may need a higher dose, or if their pain's doing well, you can't abruptly stop the drugs. You have to wean them down. That's what physical dependence, tolerance, that's what happens with opioids. Addiction is when their whole life is geared towards getting it. They have losses like jobs, money, family, despite getting the drug. And they ask for their next drug constantly. Even if they get it, they don't feel better. That's addiction, okay? So this is just my last some take-home points here, mistakes that I see docs make. Writing more than one medication on a script. So if you cannot write on one script a prescription for hydrocodone, which is Norco and Xanax. So controlled substances cannot go on one script, and it can go on to one script. It's one script per drug. And if you, let's say you have a patient on MS Contin 45 milligrams, it doesn't come in 45. You're giving them a 30 and a 15. You have to write one script for 30 and one script for 15. So just know not more than one med on a script for opioids. When you're converting IV to oral the day of the hospital, remember how long it's going to take to start working. We kind of talked about that. If you're discharging patients from the hospital going to a nursing home, make sure you write the narcotics. It's really not legal for us to call in narcotics as nursing home docs on patients we've never seen. If they come to the nursing home without a script, I'm asked to call it in on a patient I've never seen. And then multiple narcotics used in the same patient, I think we talked about that. And then poor equal analgesic dosing. Make sure you look at a table and know how to dose the medications. I think I talked about these already. Hydrocodone's now a C2. Tramadol's now been made a controlled substance. And nursing homes now no longer allow physicians to order. We have to call them in. You can't just tell the nurse to order something. If I have a patient who needs an extra dose of hydrocodone at 2 a.m., they have to call me and I have to call the pharmacy to get the okay to give it. So it's gotten so much stricter.